Good afternoon and welcome to Workshop A, Expanding Access to Care. My name is Michael Thompson. I'm an Associate Professor of Public Health Sciences and Associate Chair of the Department, as well as the Associate Director for APHI, the Academy for Population Health Innovation. And it's my pleasure to welcome you today and to be the moderator of this session focusing on expanding access to care. We're very privileged to have three very informed and influential panelists speaking to us today. They'll be introducing themselves in more detail as we go through the program a little bit later, but I'll just highlight them now. Carolyn Allison is joining us. She's the CEO of Charlotte Community Health Clinic. Sharisse Johnson is the Executive Director for the Camino Health Center, and Tchernavia Montgomery, who's the Executive Director for CareRing. All of our safety net providers working in our community. The objectives today, this session is worth up to 1 to 1.5 CEUs, depending on your provider. We're going to be focusing on having our panelists answer 4 questions, and then we'll get into an interactive dialogue. So this will be done kind of in a round robin style. The first question I'll be putting to the panelists will be about what is the unmet community need? There may be time for some clarifying comments at that point. Then moving on to the second round where the panelists would describe what their organization is, introduce themselves a bit more, and talk about plans to expand to meet the needs that we just identified. And then the third round will focus more about opportunities for collaboration, competition, coordination of care and services. And then as we wrap up, sort of what the next steps and what resources might be needed. And then we'll have more of a free-flowing question and answer session, and we'll give the panelists a time for kind of a concluding comment. So with that, I'm going to open it up to the panelists and toss out the first question. I'll be calling on them kind of just in alphabetical order. Carolyn, would you like to talk, please, about what you see as the unmet need?
Absolutely. Yeah, first I want to thank you for having me here. This is a great opportunity to share with you just my thoughts and concerns. Unmet need here in Mecklenburg County. I go back to the 2019 Mecklenburg County Public Health Community Health Assessment that was done. And in conjunction with Novant Health, Atrium, and One Charlotte Health Alliance. And during that time, that joint report, the Community Health Assessment, identified really 4 top issues, of which I really feel strongly that the top 3 are areas that we are focusing on as a community health center, and that this community continues to need attention. It's mental health, access to care, and chronic disease prevention. I also want to add to it, of late, food insecurity is a huge need within our community. We partnered with Loaves and Fishes, and a week ago, actually, just independently served or sent out over 200 meals to individuals. And that's just one resource here in this community. There are many other organizations doing the same. And then finally, the need for access to care to our increase in numbers of refugees and also immigrants in this community. That's all, Mike.
All right, thank you. Sharisse?
Hey, thank you so much for having me. So, I would echo the same. It's funny that Carolyn said the same thing. I have the same things listed, right? Your access to care, chronic disease, mental health. And when I'm looking, I come from corporate and more like Cardinal Innovations. I was a director of network, and I'm coming out into a non-for-profit world. And I'm thinking that, we have all of the resources. And so specifically for the Latino immigrant population, I see the same needs, but it's been so exacerbated with COVID. I see that, we have lack of the workforce. We have lack of students going into the workforce and getting education on, mental health education, becoming, nurse practitioners. especially at the Latino population. So I would just echo the same. It's that mental health, access to care, chronic disease, and that food insecurity. And I think we do kind of the same things. We're just touching a different population. And for me in particular, I see that the Latino population gets lumped into this Black and brown community, and we get lost in there sometimes, especially when we look at what Dr. Washington was talking about, the community needs health assessment, and we take the census data. And so there's lack of data that includes those that are undocumented, because those that are undocumented do not trust the larger entities to take and collect information about them. And so we have such a disparity on just the data itself. And so then how do we know what we need to do, and how do we know how we need to serve? So services, but of course, then the data and just the workforce would be the biggest needs that I see.
Great, thank you. Tchernavia?
Yes. Well, I am going to do the same and echo the sentiment shared by my colleagues. Access to care is definitely an issue that continues to be prevalent in our community. And access relates to making sure that services are affordable, that they're convenient, and also culturally competent. So we know that 160,000 residents of Mecklenburg County say that they would like to go to the doctor, but can't simply due to cost. And with the high percentage of those that are uninsured in our county, upwards of 16%, I think we know we have a problem that continues to grow, and we have to ask ourselves, why is that? Why don't individuals in our community have a regular source of care or aren't utilizing the care that's currently there? So I believe that that need falls along the lines of health disparity work that we're all engaged in, health equity work, and making sure that we are pouring ourselves into vulnerable and underserved populations. One unique thing that I will say that we also have a need around is maternal child health. We are very much in the midst of a continued crisis, especially for women of color. 41% of our births in Mecklenburg County are Medicaid eligible. So you immediately have a disproportionate number of women of color that are giving birth and in poverty in our county. We know that the preterm birth rate for Black women is almost 50% that of white women, and that Black infants just do not fare as well when it comes to prematurity, birth weight, and their first year of life. Black infants are 5 times more likely to die in that first year. So we have a lot of work to do in that area, in addition to the others that were mentioned by my awesome community colleagues.
These slides just give a nice overview of who we are as a community health center. And but I want to back up and go and start with our history on the next slide. In 2001, Charlotte Community Health Clinic, we were providing care to the uninsured and also underinsured children and adults in the Charlotte area. And we were doing this as a free clinic. Charlotte Community Health Clinic was founded by a prominent doctor in our community, Dr. Garmin Brown. She was one of the founders of this practice many years ago. In 2015, we transitioned from being a free clinic to what's called a federally qualified health center, or FQHC. Some individuals refer to this type of organization as a community health center, which is correct. We wanted to do this in order to increase our footprint and offer additional services by accepting Medicaid, Medicare, and private insurance health plans, and therefore opening up more access to care to the greater community. Next slide, please. Just in short, the services that we provide here at our community health center is pediatrics, adult medicine, also healthcare for the homeless. We do have a full-time RN who's located at Roof Above. She is 2 days a week at Urban Ministry and 2 days a week at the men's shelter, providing direct care. We also focus on women's health care. We partner with Upstream in order to provide long-acting contraceptives for our uninsured women and really helping them to plan for their pregnancies. Also, HIV and Hep C prevention and treatment. Want to focus on the formerly incarcerated transitions program. This is short, is called FIT, And this program is really helping individuals with chronic diseases who are coming out of incarceration. And oftentimes they're given less than a month's supply of medication, and they may not have a medical home. This program really helps us to partner with a local nonprofit in order to enable those individuals to come to our practice, have access to behavioral health, primary care, and also dental care. Integrated behavioral health, we have been providing behavioral health services since we've been a community health center in 2015. That's one of the core requirements of a community health center, is to provide behavioral health services along primary care and dental. We decided last year to start a pilot to integrate behavioral health into primary care. And what that simply means is that our behavioral health providers, they do not have a panel of patients that they see. They work alongside our primary care providers in clinic. And so when my providers have huddles in the morning with the other staff members, those behavioral health consultants are a part of that huddle and also identify those individuals who may need their services at the time of their appointment. So for the population that my colleagues and I are serving, transportation is a huge barrier. So being able to provide this service while they're on site is really excellent and helps them greatly. Medication assisted treatment program. This is part of our substance use disorder program that we offer here. And we provide services to individuals who are preparing to really work through their substance use disorder, and primarily around opioids. They partner with their primary care provider and also our behavioral health consultant in order to assist them with this transition. We also receive funding from the state in order to provide what's called the BSEP program. This is Breast Cervical Cancer Control Program. And we're able to, through partnerships, provide free mammographies, primarily for our uninsured women, and also cervical exams. And then finally, family dental services. We offer family dental services at one of our locations, and that's at the Global Opportunity Campus. And we see both children and adults. We see the uninsured and also insured. Next slide, please. Just a little bit about our patient population in 2000.
I'm sorry.
Oh, that's okay. In 2021, we provided care to approximately 5,217, what we call unique patients. These are individual patients, of which 49% were at or below 100% of the poverty level. Also, 76% of our patients are uninsured. That's unusual for a community health center. Oftentimes, their uninsured percentage is about 40% or a little bit less. We are very high because we started as a free clinic, and many of those individuals decided to stay with us, in which we're grateful for. And that's the reason why we have a high percentage of uninsured. Also, 8% of our patients are homeless, and that's through the partnership I talked about earlier. And 59% of our patients that we see are Hispanic or Latino. And this is because when the free clinic started, it started in East Charlotte many years ago, back in 2001. And as we moved the practice to different locations, and finally here to a university site and also our Wilkinson Boulevard site, many of those patients opted to stay with us, and we're very grateful. And so all of my front desk staff are Hispanic, Latino, and also bilingual. 25% of the patients we serve are Black or African American, and 10% white. Our future plans moving forward, in order to address the unmet needs that myself and my colleagues have spoken about, we were very fortunate to receive an American Rescue Plan funding from HRSA, the federal government that supplies us with most of our funding. This funding was received last year, and what we did, we opted to apply for 5 projects, and that was the maximum number of projects. And so 3 of the projects is going to be expansion of our practice between this year and next year, possibly through 2024. But our goal is to really implement the 3 clinics within the next year and a half. First of all, our partner is with Thompson Child and Family Focus. We'll be building a small satellite pediatric clinic on their campus within their Windover Road site. Second is with Outreach for Kids. They serve immigrants and refugees, and we'll be partnering with Outreach for Kids in order to build a family practice satellite office on the campus of Aldersgate. Outreach will also be partnering with immigration attorneys. So the three organizations will be all located within the Aldersgate Administrative Building, and we'll be able to serve the population collectively. And then finally, we'll be opening a clinic, urgent care, or what we call same-day clinic, at the Steve Smith Family Wellness Center. That will be one of the first projects that we should be rolling out sometime in August of this year. And that center, as I indicated, will be for same-day services or urgent care. And that will open up more access to care for individuals who need same-day appointments and may have to wait to get an appointment at any of our practices. Next slide. I think that's it, right? That is all that I have, in regard to my overview. And so thank you, Dr. Thompson.
Thank you. Sharisse?
That is impressive. I don't know how you got all of that on a couple of slides. You guys do so much great work, and we're so honored to partner with you in a lot of things that we do. So thank you. So Camino Health Center, we serve the Latino immigrant. Our mission is to equip people to live healthy, hopeful, and productive lives. We've been around in Mecklenburg County since 2003. We were formerly Bethesda Health Center. We've been providing services and community from our site in the university area since 2003. And in 2021, we got a site in Concord. And so we're looking to expand also as we go forward. And I'll share a little bit more about that. You can go to the first slide. So this is a lot. This is what you should not do on a PowerPoint slide, but I was trying to condense everything that we did as well as give information. Specifically for the Latino population, this is, and like it is for most minority populations, right? But I can speak very clearly about the Latino experience and especially the immigrant experience. So we offer a low-cost primary care clinic where our hours are Monday through Friday. I'm not going to read all this. Everything that we do is bilingual. Everything is Spanish first. So we make everybody else feel uncomfortable, like we feel uncomfortable going to other places. Everything that we do first coming in, our people that our staff all speak Spanish. Everything is Spanish first. We are for a National Association Free and Charitable Clinic. We're Gold Star rated. We have a low cost, and then those that people can't pay, we have a sliding scale that we use for primary care. We provide like vaccines, labs, pediatrics, vaccinations, like I said, and we do chronic disease management. And so because we started there, we started with 2 days a week, we started with volunteers, we saw the need and we expanded to have paid staff. And then we started collecting data. The one thing that we really did was, we have a community-based research team, and they're the Camino Research Institute. You'll see some of that on the slide later on. We made sure that we invested our time and our resources in data collection and making sure that we were data-driven and outcome-based. As a grassroots company, you would know that it's very difficult to secure funding and any of those other things if you don't have the data and you don't have those means. So that was one thing that we decided to do very early on. And within that data, we showed that, 56% of the people that we serve in had high cholesterol, had had diabetes, had, higher BMIs, obesity. And so we developed out of that the Camino Vida program, which is life. And it's a health and wellness intervention program. It serves the clinic patients that have chronic disease symptoms. Again, diabetes, high cholesterol, obesity. We do one-on-one nutrition consulting with our registered dietitian. Again, everybody is bilingual and they're Spanish first. We have personal and group training sessions with fitness specialists. We provide nutrition, exercises, classes, and that's open to the community. And we recently just started diabetes support group using the DEEP, which is the Diabetes Education Empowerment program that is really geared to the minority population. So really hitting on the Latino. And what we do there is really try to teach culturally appropriate food preparation. No one is going to eat macaroni and cheese or quinoa. We're just not going to do that. We need to learn how we can eat tortillas and arroz con gandules and those type of things. That is what part of our culture, and it makes who we are. Food is very important to us. Family is very important to us. So everything that we do has our culture at the heart of all of the services. Next slide, please. So we had started about a couple of years ago, we started doing behavioral health services, and we started with interns with UNCC. Very much love our relationship there, or else we would not be able to do what we do without the interns and the support of UNCC. So that's a plug, Michael. Thank you for all that you do for us. And so about a year ago, we were awarded some funding from the state, and we were able to hire just some actual licensed clinicians. Love our interns, but actual licensed clinicians to work with our interns and expands our behavioral health program. And so now we have a psychiatrist that's on staff. She's our medical director for behavioral health. We do psychiatric services, med management, therapy, individual group. We have a licensed child play therapist for our children. We've learned that in order to get if we can get the children in and we get them taken care of, mom and dad will follow. Well, usually mom first, grandma, and then dad, perhaps, right? In the Latino population, dad comes last, but family always comes first. And so gearing everything that we do to the family and to help offset stigma, we do parenting and support groups or wellness groups as opposed to mental health groups. We don't really like that word, so we'll stick to those type of things and really try to gear it towards, how they can help out their family, how can they do better and feel better to help support their family and be around to see their grandchildren grow up. We also have peer support services, which is a fidelity-based service. That's a person that has lived experience and walks one-on-one with someone that has a mental health or substance use disorder. We also teach peer support training, mental health, first aid, QPR. And the heart of our behavioral health program, believe it or not, is our social navigation program, which focuses on the SDOH as your social determinants of health. I say social influences of health because I don't think everything determines my health. I think it's an influence. I think I have power over that, but it is a barrier. And so that is it's kind of the case management on steroids. We are making sure that everybody that comes in through our doors have contacts and connections to resources. People like Dr. Washington stated, people are not going to get healthy, not go to the doctor, take their meds if they don't have a place to live or a job or food on the table. And so we concentrate on that. And that is where we're able to build that trust and offset some of that stigma with the Latino population. And so we do a lot of social navigation. Usually that's the first door into behavioral health services. We also practice a fidelity-based model called collaborative care, where people are coming in through their primary care physicians. They're doing an assessment with them. If they meet the assessment requirements, they're then staffed with an integrated care manager who staffs all their cases with the psychiatrist and our medical director, our medical doctor, Dr. Pryke, and works holistically. And so that is all of our services. We're working together. We're working family. We're working on the whole person. It's very, you all know, you all heard, it's not a secret. It's very important, but in particular for the Latino population, people are going to come in when they're hurting and they can't go to work and they can't take the day off, or, that's when they're going to come in. And so how do you get them while they're at their PCP? I get my meds from my PCP. I don't get it from my psychiatrist. And so how do we integrate that behavioral health into that primary care setting? Super important. And then we have the food pharmacy that is part of the Camino Vida, which is a pun on pharmacy, but it really is to live, to eat, to live, to live, to eat. We provide access. We are a Loaves and Fishes site, and we provide access to our food for our community. We address food insecurities. We work in collaboration with Camino Vida to do nutrition classes to make sure that the food that we are giving them actually adheres to their diet. It's nothing like going for preventative medicine and getting all of your primary care, then getting your behavioral health because you're stressed, then getting all your resources. And then the one thing you lack is food, but now I'm giving you food that is contradictory to everything else that we're telling you to do. And it's not culturally relevant. So we're making sure that, we're trying to to build that, to bridge that gap. And so this way you're holistically able to be sustainable and be able to have this as a lifelong change, not as this, intermittent, changes. Oh, I lost weight. Great. And, that this becomes a lifestyle. So we're super excited about that. Next slide, please. And then we have this new program, Quahi, but we've been doing it for a long time, but we just made a name and we put a nice, pretty logo towards it. And we kind of professionalized a little more. We're doing employment where this program is Arriba, which is upward. It's promoting social economic upward mobility of Latinos. This is where 50 out of 50 is not good enough in the social mobility area, right? We got to do better. And so working on employment readiness, job fairs, resume building. We just had an affordable housing a fair that we had. We do entrepreneurship and financial literacy, access to college. We just applied to become a GED site in Spanish, one of the only ones that I know about. And then we teach ESL classes and we provide financial services like tax preparation and such. Again, the same thing is that, I can't go to the doctor if I don't have a job. And 99% of the people we serve, I had like 7 people. We're trying to build Medicaid and do all that one thing. And I had 7 people last year that I billed Medicaid for. Everybody else was uninsured. So that's our reality. And so how do we work within reality without gouging and taking advantage of people and where they're at? Because, our people can pay. It's just, we got to pay for quality services, and we want to pay for services that are relevant to our culture in a language that we can understand. And then this is we have Camino University, which is something that is really grassroots for us. It's educational opportunities to the Latino Hispanic population. It's programs that eliminate affordability, language, and geographical barriers, where this is our equipping piece of our mission to become community and service oriented leaders, focusing on developing that leadership with community education, professional development, and accredited learning. This is where we teach peer support and those other services. We recently just received one of 13 peer support manuals in North Carolina, and we're working with UNC Chapel Hill on recertifying that manual and also translating into Spanish so we can start teaching in Spanish the peer support training manual. So we're excited about that. All right, next, I feel like I'm rushing. I apologize. That's the New York and like 30 slides into 2. So. And then, our Community Research Institute, we have, like I said, we have a team of community-based researchers. And I just wanted to throw this in here. This is our plug to do the Latino community needs assessments and needs. The biggest thing that we see is when we see the health assessments and we see all the data that comes out, it doesn't necessarily. So while you see that, yes, 20.5% of the poverty rate is Latino and Hispanic, I imagine that you got 4 in the car, 10 in the trunk of those people that are not answering those. And so I imagine that number is a lot higher because people don't trust those type of, agencies and governmental and just education in general, because where they're from, those are government agencies, whether you're not-for-profit here, like Atrium Novant, and wonderful community-based like UNCC, they leery on that. They're very, just not trustworthy. And so we built that trust. And so a lot of the people that we have complete these surveys they indicate they're undocumented. And so that just shows the trust that we have in the community. And so this is a 15-minute online survey. It's created by Latino community leaders. And then the criteria is only that you have to be Latino and you live in North Carolina, 18 over. So I'm plugging that if you know a Latino, and most of you do, please go to camino.org/survey and just take 15 minutes, because this will inform not just Camino, right? It will inform the state as to where we need. And then this, coupled with the wonderful work that the health department does, coupled with the census, coupled with UNCC and whatever they do, will then be able to build a stronger story and tell our story the right way and tell it, the way that we need it told, and not by people that are sitting in, high houses that think they know what we need when we can tell you what we need. So that's just my plug for that. Next slide. That's it. I'm done. Thank you.
Great, wonderful. Thank you, Sharisse. Particularly the shout out for what our students are doing in the workforce development. Tchernavia.
Yes, thank you. All right. Well, we are Caring, and we can go to the next slide. Caring has been around for nearly 7 decades now, and we have traditionally been within the realm of providing affordable, high quality, and accessible services to those who are uninsured. We are, unlike my colleagues, we do not accept any form of insurance, including Medicaid, and that allows us to live in that special place where we can focus on the uninsured population. And we know that that is a growing issue in the community, again, up to 16%, which I think that number is low. I'm going to give Sharisse a nod and just saying that some of our population may not feel comfortable sharing that information when we're doing public surveys or collecting census information. So I think the number is probably close to 20 to 25% of adults are uninsured in Mecklenburg County. We also have those that are on the cliff. We do have individuals who are underinsured that come to us for services. So maybe they have a health insurance product, but because the deductible is $500 or the copay is the difference between going to an appointment or filling up your gas tank, they may come to us because our services are more affordable. We are thankfully able to offer a holistic continuum of care. We offer prenatal services all the way through end of life services. I think our oldest patient right now is like 93. And we are happy to be providing that care as they gracefully age. We can go to the next slide. So here's a little bit of a snapshot of what we do. Our helm is our low-cost clinic. That is the way that most of our patients enter into our continuum of care. It is your normal, everyday, run-of-the-mill primary care clinic. I welcome you to come visit us and check us out. But what you'll find there is no different than any other clinic that you'll find in the community. We offer well woman care. We offer vaccinations. We do employment physicals and school screenings. We do chronic disease management incredibly well, and we are able to fill in the gaps where others may not be able to get comprehensive care otherwise in the community. From there, if someone has a need that we in our clinic cannot meet and it requires specialty care, this is where our Physicians Reach Out program steps in. Physicians Reach Out is a comprehensive care program for people with limited resources, but are needing access to specialty care. The best example I can give is, let's say we're doing a well woman exam in our clinic and we find a lump in a breast and we suspect that it may be cancerous. We can coordinate care for a very small enrollment fee of $45 a year, connect them to Levine Cancer Institute, where they can then get treatment through the course of their illness free of charge. They are not billed for this care. This allows us to ensure that individuals are not experiencing worsening health because of that continued lack of access to care. So Physicians Reach Out has been incredibly successful, and we're able to, again, connect with our different partners in the community. Our 2 health systems, Atrium and Novant, are incredibly generous to us with Physicians Reach Out, in addition to a number of other care providers in the community: Charlotte Eye, Nose and Throat, Ortho Carolina, LabCorp, Charlotte Radiology, the list goes on. And we have currently 1,600 providers that provide us with time or care in some way, shape, form, or fashion. And that gets us to a pretty big number at the end of the day for care provided. Then next is our Nurse Family Partnership Program. This is one of 2 maternal child health programs that we are able to offer with Caring. Nurse Family Partnership and our new program, A Guided Journey, which is a partnership with Mecklenburg County. Both seek to enroll pregnant women who are at risk or vulnerable up through, with a guided journey, 3 months postpartum. With Nurse Family Partnership, we have to connect before the baby's born. But both programs provide that prenatal care, specialized education, a targeted intervention approach to those vulnerable families. And they work with the families until the child turns 2, at which point we hope to have a warm handoff to another program that's able to continue that home visitation and that case management for that family. Currently, we are serving a combined 500 women with both programs, and we are already geared up for some expansion for both programs in the next fiscal year. And then last but not least, our community-based care. We are trying to do better about getting out to where people are versus expecting them to come to our brick and mortar locations. So whether that be participating in the roving vaccination site clinics, providing neighborhood services. We've had a relationship with the Greer Heights community for 2 years now, or our COVID-19 health literacy workers, we are getting out into the community to provide care, to build trust, and to make sure that we are providing a type of care that's needed for whatever population we're approaching. Our vaccination clinics have been very, very well received, and that's because we are using our trust that's already built into the community to reach out and encourage vulnerable families to get the vaccination. So we've had very high attendance rates, very low no-show rates, and we know that that is not always common with vaccination clinics in the community. With our case management program that underlies all of these programs, we're able to ensure that we're capturing those social determinant of health needs and screenings, and we're able to do, for instance, diabetic education groups that are geared towards our Latinx patients, or we're able to address food insecurity, transportation. We use Uber Health if needed. We don't want transportation or another barrier to be a challenge and for someone to forego care. Next slide, please. A little bit about our patients. This number needs to change. We're now at 94% persons of color. Our average income, it fluctuates anywhere between $17,000 to $19,000 a year. Of course, with COVID, we saw fluctuations to that number. We are very deeply embedded into the priority health zip codes in Mecklenburg County. And those are the ones that are experiencing higher rates of food insecurity, higher instances of access to substances, less green space, more violence, and those residents tend to have lower education, and all of that just results in poor health outcomes and a poorer quality of life. And thankfully, because we have the approach that we have, we are able to arrive to a place where even though half of our patients arrive to us with an unmanaged chronic condition, within 1 year, 75% of those individuals then have managed illnesses. So we are able to help them move beyond having the pain of that illness and experiencing that day-to-day challenge, and help them graduate to a place where they can go to school, where they can take care of their families, where they're able to resume their education and not have those limitations forbidding them from being able to achieve what they deserve. Next slide. Just a little bit of a snapshot and review. We deployed a virtual visit platform during COVID that has been highly successful. We've gotten great feedback from our patients. The majority of the patients that carrying across the 8,000 or nearly 8,000 individuals that we serve have had at least one telehealth visit during their time with us. That includes our maternal child health program. So it's been very successful, very much a way for us to ensure that we are reducing our risk in the office as it related to COVID, but also making sure that our patients continue to have access to our providers. We saw lots of babies born, and we reached more patients than ever with physicians reach out and continue to have that upward trend. And all of our programs altogether saved an approximate $15 million from avoidable ED visits. We know that with the populations that we serve, and I know this is the case with both Sharisse and Carolyn, will say that unfortunately, because the emergency room can't turn you away, you might go to the emergency room to get primary care. You may have a migraine or an ear infection or a rash, or just need a refill. We have seen some of our patients show up at the emergency room just to get a refill. All of these issues can be addressed in a primary care setting when individuals have access. We have received lots of awards for the services that we provide, American Heart Association and Diabetes Association. We are also a gold standard clinic with the National Association of Free Clinics. We won a national award with the Healthcare Leadership Council for redefining American healthcare, and that was the result of the work that we do with low-income populations around social determinants of health. And we were the winner this year of the Charlotte Business Journal's Healthcare Heroes Award. It was a virtual program, and I promise you, we made a lot of noise, and I heard people down the hallway shouting. So we were very, very, very excited to be given that opportunity. And then this little blurb in the bottom, again, we are doing better about getting out into the communities. One of our partnerships that we're very proud of recently is that we've taken our maternal child health programs into the jail. We know that women are especially vulnerable during pregnancy. And if you add the factor that they are incarcerated and basically set up for a lot of negative statistics when they're released, we want to make sure they have the support that they need before they transition back out into the community. And we will hopefully be able to provide or be a source of support for them. Next slide. We are able to do what we do because of the secret sauce that is direct services. combined with that relational capital, those community leaders, right? We want to know who the informal leaders are. It might be Miss Sally that sits on the stoop in the neighborhood, and she is going to either help you or hurt you, because she, with her trust, can help make sure that residents know that we're present and that we're available and accessible. We partner with our grassroots systems, our large systems, to make sure that we are aligned to what their trajectory is and their goals and objectives are, and that we're adding a source of support for them for populations they may have a harder time reaching. All of this allows us to have a very holistic community-based care model to address health equities and disparities, and continue to make sure that we have our ear to the ground and are listening and building trust. Next slide. That's it for me.
Great, thank you, Tchernavia. Appreciate that. It's impressive to hear, the similarity across the vision about what the unmet need is from the first question, and then hearing how each of your organizations and your primary geographic focus is spread across the city, from University City to kind of Center City down near the airport a bit more. That while recognizing the same need, you've each adapted and brought out various combinations of services and approaches while retaining and expressing some of the very similar values about how to serve your communities. Can you say a little bit, and we'll go around the ground again, about where you see as opportunities for expansion, collaboration, coordination, and so forth, as you try to tap into this unmet need? Carolyn?
Sure. Yeah, very good question. Coordination around addressing the unmet need. I'm a strong believer in collaboration. As a community health center, we thrive off of collaboration. Our model is very, very different than a private practice. We partner with at least over 20 different organizations, local and also around the state, and sometimes nationally. I think that it's mental health. I just want to stress that is one area of highest need that I think that we can really leverage in working together. A lot has been placed on primary care practices in regard to just the lack of access to care for individuals suffering with behavioral health issues, and especially coming out of COVID, looking at just the poverty rate and access to food, et cetera, many of the challenges that my colleagues have shared, that I see that that's an opportunity for us to really begin to come together, not only look at, as Sharisse shared, the importance of the data, but also, who is best to serve individuals. Even though, I love what we do here as a community health center, we cannot do it all by ourselves, and we need the partnerships. And I look forward to that. And finally, just the opportunity to share on the One Charlotte Health Alliance Advisory Council is a great opportunity to work with new colleagues, but also work closer with the two hospital systems and also the health department in order to come up with strategies for us to better improve collaboration.
Yeah, so for me, for collaboration, like Carolyn said, we would not be able to do anything that we do without, especially physicians reach out, without caring. A lot of the people that we serve, don't have insurance. Most of the people we serve don't have insurance. And so physician caring is our specialty care, and we refer quite a bit, I would say, most of our people to caring. And so there is this just this respect that we have for one another, because we are in just different, we're serving the same population and we just have different niches, and there is no competition. There's so much need out there that there's so much work to do. It doesn't make any sense. We just get together and we'll just figure out what need and what can you do well, what can I do well, and how do we work together to just meet the needs of our community. the biggest thing that we see in Camino is that we, are connected also to a church. We're not faith-based, but we are faith-filled. And so we rely heavily on the faith-based community. And that is really important in the Latino population because they trust their ministers, their priests, and so we dig into that because that is where we're good at. That is our niche. That's our secret sauce, right? Is to really dig into that faith community and really use the trust that they have with the people that they're serving, and how do we get to them? We recently was awarded through the state fiscal rescue funds from the state. We were written into the legislation for $7.5 million, and that is to expand all of our services on a mobile level. We purchased a mobile clinic about a year ago. We've been taking that into the community. We're upfitting it now, so we'll be able to do behavioral health and telehealth in there. We were awarded money from Mecklenburg, and so the collaboration is endless because we live in Mecklenburg County, and Mecklenburg County has probably one of the best counties I've worked in that would able to see the need and able to give towards these grassroots efforts, and to see just what you can tell what they find important in what they fund, and very much see that in this last rounds of ARPA funding that they gave out. So, the collaboration is I'm always looking to collaborate. And for us here is a lot towards the people that come, you get lots of people that want to serve with you and give, especially because we have a church connected. So you'll get church groups that come. And really the transformation is for those that are serving and also for those that are being served, right? You can, because a lot of people don't know where to give or how to give, and we offer them the opportunity to do that. And so we're not only changing the life of the person that we think is the receiver of the services, we're also changing the life of the person that's able to give back to the community. And that's where we see full transformation in our community. That's where you bridge the gap of the haves and the have-nots, is be able to work together. Expansion, like I said, was we're going into probably 6 counties here in the next 3 years with that funding that we received. We've expanded to Cabarrus County, and we're probably going to Guilford next. But we're a service agency, and so we want to go where the need is. We're not here for competition. If you do that well, I'm not going to do that service. If we go someplace that has a wonderful FQHC, and and we don't need any of those services, well, then where can I work with the community to meet the unmet need? I am not trying to do something that someone else is doing. I am trying to meet an unmet need and trying to do it well and the best, because that's what the people deserve. They deserve quality. They don't deserve competition.
I totally agree. And this is really what community should be, right? I'm not trying to open up a dental clinic. We send them to Carolyn. We don't have the capacity to do research. So Sharisse, yes, send your surveys to us so that we can give them to our patients and you can collect your data. There's so much need. And even with the 3 of us here on this call, we are still just scratching the surface. And that's the need here in Mecklenburg County. Never mind all the other places that need support. So we're overwhelmed. I think the opportunity does come in the form of collaboration and synergizing. COVID's been an absolute wonderful way to force that. Unintentionally, it got us out of our comfort zone, and we had to do something differently if we wanted to be successful and not see the need continue to worsen. One thing that we've made sure that we're doing is incorporating voices of people that are going to get the services. We have our first member with lived experience that's serving on our board. We are making sure that we're including patients in different forums that we're having, talking to those who have graduated services with us to ask them, what was positive about this, or what could we have done differently or better? So I think there's always an opportunity to be more thoughtful in your programming, and respecting where people are coming from with their healthcare journey. Too often we do things to people and not for them or with them. We expect something in return. And I think we are getting better as a community about working alongside individuals who are getting the services and collaborating with them on their health, because we're not the experts, in case we hadn't, in case we've forgotten. we want to make sure that we're incorporating that patient voice into what we're doing. I think there's always opportunity for policy changes that acknowledge the historical trauma and the desperation that's sometimes felt with certain communities. And last but not least, there's always opportunities for different systems of accountability. We are 3 different clinics here on this call, and through our different funders have 3 different sets of KPIs and measures and metrics. And there's no one universal answer to what is successful. And that's something that I think we are going to grow towards and work towards. I know Carolyn and I are both on the MedAssist board or MedLink board, and we are working very hard to try to encapsulate and envelop all of the different organizations that make up healthcare in the community so that we can get to a better place of shared understanding, shared accountability. We know there's common thread in the people that we're serving. So if we continue to operate in a silo, then we're going to continue to fail at what we're trying to accomplish. And last but not least, board diversity. We are at last count, we're 46% persons of color on our board at our organization. It did not look like that a year ago. So we made tremendous stride last year with diversifying our board because it is important that leadership be representative of the people that we're serving. That is still an opportunity that is held with lots of organizations in our community. So there's lots of persons of color and people of different ethnicities and backgrounds and skill sets that would be more than happy to serve on a community board, and we need to tap into those resources and those expertise more often and utilize them.
Great, thank you, Tchernavia. I think it's kind of bittersweet to hear how all of you are working very aggressively to expand your services and addressing some of the problems. At the same time, that reflects the underlying scope of the unmet need and so forth. So the last of kind of the structured questions really is focusing on about what kinds of resources, systems, technologies, approaches do you see that might be useful to help you in this shared mission?
You know, I'll go in the sequence. But, you know, I see one of the approaches from a technology standpoint, going back to COVID and being thrust into telehealth. And we even went as far as teledentistry and received an award for our teledentistry program. But across the board, it's just not us. Organizations, you know, are really using that technology. And I think that that technology is really to help open up access, you know, to services to so many people who had difficulty in accessing our services. We also use the technology via the homeless, you know, shelter, so that they too can have access, you know, to the services. From a collaborative standpoint, you know, I have to really echo what my colleagues on this call have said. You know, there's so many opportunities to collaborate. We really need to continue to put ourselves out there to be the voices for people in the community. I don't say who do not have a voice, but their voices are not being heard. And so the responsibility is on our shoulders, you know, to really go to those individuals who can make a difference. And one goal that I have, especially after participating in this forum, is to really partner, you know, with my colleagues here and within the community to make a difference in healthcare policy. Because that's the beginning of, you know, what occurs at the community level. If policy doesn't change, the funding doesn't follow, and therefore we are limited, our hands are tied. But if we can collectively, with one voice, go to our elected officials, not only at the county level, city level, but state and also federal, how powerful would that be? And that's something strategically I'm going to be really thinking about more and discussing with my team and with my colleagues. That's all.
Yeah, so specific to technology, you know, when I came on, we were using a system that wasn't going to work with traditionally technology is working for the EHRs, and those type of things. But I think that as we move forward into this holistic care and this whole population health care, I think that technology is far from ideal where we need to be able to just, capture everything. I find it difficult. We started with eClinical Works and it's super expensive and it's not in a language that I can work with my staff. So when we look at the population health module of that, it's in Spanish, but it's not in Spanish, right? My Spanish is not technically Google Translate. So I struggle with a lot of that. And so, we have partners that have access to other EHRs and, we're not able to share information. I may be serving the same people Carolyn is serving or, and we don't have access to that. I know the legislation has tried to put this request for the HIE or this mandate for HIE and everything. I don't see it's not helping me. I'll say that. And so how is it helping the people that are actually seeing, these patients? Yeah. So, and it's not the Medicaid population, it's the uninsured population, it's the underinsured population, and that is who we're missing out on. So that's my piece. I would love to see a kind of a population health that would really look at holistically mental health and just all the requirements for HIPAA when you talk about substance abuse and all these type of things just come into one that's not going to rape me. Because it's so expensive. I'm sorry, but that, and I just can't do it. And here I am trying to plug together and my staff hate me because, I'm trying to create something that is useful for them, but it's a lot of work and it's a lot of money. But in the end, hopefully we're able to gather the data and record data off of it. It's, hopefully it'll be worth it in the end.
Yeah, so very similar. We tried to do our best to adapt to some of the platforms that are available. I know we have the Community Resource Hub with Atrium Health, and we have taken a very deep dive into NC Care 360. It's the state's first coordinated care network to connect individuals and local resources to different organizations, and it allows us as an organization to have better visibility into the other partnering organizations. We are hoping at some point, to my colleagues' desperation as well, for some sort of universal answer or better definition of what we organizationally can do to drive us toward maximizing all of our opportunities. That probably lives within some sort of data platform. But we want to drive and manage our performance. We want to find innovative ways to serve our patients. We early on in the pandemic also realized that COVID was going to be a barrier, but there was this digital divide. So we had to take advantage of the opportunity to create a telehealth platform. It's gone very, very well for us. And then we also realized that, maybe you do have to take your appointment out of your car outside of a McDonald's on your cell phone. Is it better than not seeing a doctor at all? Is it better than not attending to your care? So we've had to meet people where they are, also electronically, or helping people apply for different opportunities that might give them some form of Wi-Fi service in their home. Individuals have used their kids' Chromebook, right, to do a virtual visit or a telehealth platform, and that's fine too. It's better than nothing, but I think we still continue to not allow some populations or some groups of people to have the same access to things that we very much feel are a right and not a privilege. But when you allow them the ability to utilize those different mechanisms, their health gets better. They're able to better meet the needs and demands of their day-to-day lives. We also realized that a lot of the individuals that were impacted most heavily with COVID were frontline workers, essential staff, who don't have the ability to take a whole day off to come to a doctor's appointment. They don't have the ability to take 3 buses across town to get to a doctor's appointment. So we've had to use and deploy different means of technology to ensure that our patients continue to have access. Let's see, risk stratification software. We have a new platform that we've deployed that's going to help us better perform population health for those who are high needs. We are hoping that this fares well. It's a new form of technology and we're going to see how it goes, but so far so good. Those patients that are most likely to utilize the emergency room are popping to the top because of their health data that we are able to obtain from EPIC, which is our local health systems, both of the EMRs that they use. So we're very excited to see where that takes us and make sure that we're aligned in providing treatment methodologies and interventions that align to those they may have received with the other healthcare systems, and we can better follow the patients on their journey.
Great, thank you. So that ends kind of the more structured part of the conversation. So please start entering your questions or comments into the chat. And in the interim, I have a few more questions I'll throw out, but this is less of a scripted sequencing, so feel free to jump in among the panelists as appropriate. The first point I'll raise is kind of echoing a question that was brought up in the opening session about the potential for Medicaid expansion and how you see that as being a help or a hindrance. And a related point that came out today was the potential rule change for the EC by the Biden administration that would change the rules for support for family members and ACA subsidy eligibility, whether that would be, how that would affect the communities that you're serving.
You know, I'll go first as it relates to Medicaid expansion. That would be significant for, you know, the state. And it would directly impact, you know, our practice as a whole. The data that I showed earlier, out of, you know, over 5,000 unique patients being served, we have 76% uninsured. The practice that I oversee, we have to pay for our overhead, providers, salaries, et cetera. And so having a high uninsured percentage makes it very, very challenging. And we seek many, many different grants, and we're very grateful for community grants, foundation grants, et cetera. Medicaid expansion would increase the number of individuals who are eligible for Medicaid. And that would be huge for us. And we can therefore begin to focus even more energy on program planning, on social determinants of health, and how we can begin to address it even further, versus really carving out a lot of time on the financial sustainability of the organization. Increasing access to the Affordable Care Act, Obamacare, you know, once again, would be huge for the population that we serve. And just taking away a lot of those barriers for people who truly need to have that type of coverage.
Yeah, for Camino, it's a little different. Well, so I absolutely support it. It'll be great for our community. It just is not going to be as impactful for our community because most of the people that we serve are undocumented and would not qualify regardless if we did Medicaid expansion, right? And so that is where we stand. And so we're still trying to fight for funding and those type of things. Again, you know, we can build Medicaid. That would be great because we'll be able to see maybe the kids and, you know, but the reality is that is not going to probably put so much impact on who we serve as a clinic or as an agency. And also for the Affordable Care Act, I would love to see, well, so the things that I hear, and I hear directly from the people is, and that again would not, we wouldn't qualify the undocumented for that service. But what I also hear from those that do qualify for that is that a lot of it is such a small cost, and which is great. But what we're not seeing is, you know, it's not inclusive of a lot of preventative care. It's more that crisis management. It's more those bigger crisis thing, like ER visits and stuff like that it would cover, and not that preventative care piece, which would cost them way more than. So that's what I'm hearing. So that is anecdotal, right? That's just from what I'm hearing. I don't know if that to be the case, but that is what I hear from my staff here who are trying to get some of that and from their families as well. Yeah, that's about it.
Yeah, and for us, it will not likely change a lot of the course of care and services because we are all uninsured. The programs that we do have Where our patients do have insurance is most likely through our maternal child health programs, and that's because we are not providing a Medicaid reimbursable service. We are hoping that will change and are working very hard to get Medicaid reimbursement for those services as other states do, because we know that our outcomes are contributing to the healthy birth outcomes and postnatal state of women of color in the community that we're serving. So while we're working diligently on that for our clinic areas, physicians reach out, that's a volunteer provider program. Medicaid expansion is not going to impact us. There will be individuals in our community that will never qualify for Medicaid. Let's just be honest, because of their immigration status, or that they are choosing to earn a few more dollars on the job, and therefore maybe their children qualify for CHIP, but they do not qualify for Medicaid. And they're on that income cliff where they won't be able to afford a health insurance product. Some of the more affordable products that are with the ACA are for catastrophic coverage only. So unless you're going to the emergency room, that comprehensive regular care or sick visit, those things are still very unaffordable. So there's work left to be done on the policy front to help create more diversified products, right? It's a great start. I'm glad we have the ACA available, but there are still gaps in coverage. As far as the recent changes with the legislation that's being proposed that's going to remove the reimbursement for COVID vaccination and testing, again, likely won't affect us. But I'm very grateful that we have two hospital systems that I believe are very well prepared with any sort of issues that they're confronted with as individuals are unable to receive reimbursement, or they're not able to receive reimbursement. And I don't believe it's going to impact us as heavily. But should we have another surge or another variant that enters into our community, I do think it would put pressure on the hospital systems to ensure that we're still keeping up with vaccination rates and testing. So that does concern me. We are communicating that information to our patients and encouraging them to get the vaccination as soon as they can, and not wait until we are at a state where there's a cost associated with receiving either or. So we're going to continue to work diligently towards some of those efforts, and are hoping to partner, like with our friends at One Charlotte Health Alliance, and I see Annabelle on the call, continue to partner with others that allow us to be able to mobilize and get that message out as much as possible.
Great, thank you. From one of the questions in the chat, let me paraphrase it. Several of you touched on the sort of the requirement to expand to more telehealth delivery during the COVID pandemic. Are there other lessons you have learned or innovations that you've adopted that can go beyond just responding to the pandemic?
I think the value of trust. Our COVID clinics that we've had, we've been successful in facilitating them because we are literally calling people. Right? We're not just throwing a flyer up on the wall or sending it out via email or hoping that someone finds out. We started out by calling our patients that we knew had vulnerable health issues and talking to them. You know, we've been providing your care. You trust us. This is what we recommend. You're at risk. Calling our patients that we knew worked non-traditional hours to say, hey, we're going to have a late afternoon clinic. This might be the best one for you. We Uber healthed people to us. We have gone out into the community with different providers that allowed us to mobilize. But trust is so important. This is a message that was not easily communicated. We have historical trauma as it relates to medical care and large systems. And to hear it from a community provider or someone that has really been with you at the pinnacle of your disease and helped you to achieve health, that means something. Hearing it from someone that looks like you or has a historical context like you, trust has helped us to achieve the success that we've had during this pandemic. And without it, I think we would not have fared as well and would have had far fewer outcomes to celebrate at this point.
Yeah, I 100% agree. When we did COVID clinics with Mecklenburg County, we had our own providers calling and making appointments and out there actually administering the vaccine, where Mecklenburg County was there. That was wonderful. They were just helping, volunteering and doing, crowd control, not necessarily interacting with the patients, because they wanted to be with the ones that that was their doctor was actually administering, the vaccine, as well as making sure that one thing that we did learn, and I'll say this, is that, with the COVID vaccine in particular, the paperwork, Mecklenburg County did a great job in truncating what we had to submit. Didn't ask for IDs or anything, but even that little bit was so difficult for our population to maneuver through, because the words are not everyday language. They don't understand how that's going to impact their sickness. If you have 3 or 4 of this, I don't even know I have 1 of those half the time. So it was very confusing. And so to have somebody there, we had about 100 bilingual volunteers out there all the time, just going through the paperwork with them. And that in itself, I mean, we had 100+ success rate on vaccinations because of that. In addition, we also started telehealth, and that was, I think what helped with that was the schools going digital. And so the parents did have to learn that. And so, yes, they were using their own Chromebooks and using that technology and learning that piece. And their children are the ones translating for them at a doctor's visit, which is, crazy. But I think that was one thing we learned, was also to take it to their community. Latinos, our population, they didn't necessarily open up to telehealth until later on in the year, when it was just the schools were closing constantly. They are relational and they wanted face-to-face. They didn't understand why we weren't face-to-face. And so having that constant conversation with them, we did not close down. We did what we were supposed to do per the public health chart, per what we were told to do. But a lot of the stuff we did face-to-face, and we just had to, or else people weren't going to get their needs met. And so, we bent a little bit, not so much that we would get in trouble, but enough that we can make sure that our people are getting served.
Yeah, learning from, the COVID pandemic, really reconnecting with community. And that was huge. Really rethinking, how do we reconnect? We were all forced into the community to go to where the people are. And one big example is, for us, was with the Asian community. The Vietnamese community reached out to us, and it was during a time when there was a lot of violence toward the Asian community across the country. And they were fearful to go to the large COVID events. And so we went to the Asian Mall, and we served the people there where they felt comfortable. And we were able to serve over 300 individuals to get them vaccinated. And so that was huge that was a huge learning for us. And it sounds real, real different, but as a community health center, that's really should be at the core of what we do. And it was really helping us to shift our focus back to community. And so as a result of the pandemic, we hired community health workers, social work, and more social workers on staff, and actually created an outreach and enrollment department, so that it's not only COVID that will be, responding to in the community, but chronic disease, making sure that individuals in the community are connected to services, and doing it in a very coordinated way. Thank you for that question.
Great, thank you. Another question from the chat, I'll paraphrase. Is your sense of the demand, is it a question of generating demand, that we have enough resources to serve everyone, if we can be efficient with what we have, or how much unmet capacity do we have to deliver the services that are needed?
I think the need is greater than what we have available in the community. Thus, you hear all of our efforts to try to expand and diversify and be creative in how we meet that need. I trust that all of us are very responsible with the dollars that we are given. I know for us, 92 cents of every dollar goes towards patient care. Right, there's not much left to be able to ensure that we are able to be competitive as it relates to meeting that need, not amongst each other, but just to meet the need. We are working against a tide of barriers and changing needs. A good point would be that our infrastructure here in Mecklenburg County has not kept up with our population growth. So poverty is getting pushed further and further out. Thus, our patients are having to take more buses, or, bless them, the cars that they have that are not reliable, or their work demands aren't allowing them to just take a break, right, to go to the doctor. So infrastructure, that impacts accessibility. And so we're working against that. And I don't see that changing anytime soon. Unfortunately, I tend to be half glass full, but there's such a great need. And I think it makes it very difficult for us to, we know we're doing great work, but when we leave every day, there's more that can be done. Now, whether or not we have the funding to do that, or if we have the energy, this is really, really difficult work. There are patients that come to us that haven't seen a doctor in years or never. There are patients that come to our door that have never seen a doctor, at least not to receive comprehensive care. So sometimes our nurse practitioners are spending an hour. I don't know the last time that you went to the doctor and were given an hour with your practitioner, but the need is so great, head to toe, with our patients, not to mention mental health, spiritual care, them just feeling confident enough to continue day to day. So it's a very complex need that requires, unfortunately, a very complex solution that we're all working towards. But yeah, it's a challenge. So if you have a secret recipe or answer, then let me know.
Yeah, completely agree. And to add on to that, the workforce that you need to actually work with this population and to work culturally relevant, being Latino and, and being bilingual, is you add that on top of everything. And then people coming here that, have their status questions, and they come with these wonderful certifications. And in Argentina, everybody's a psychologist, but they come over here and we can't use any of that. You add those barriers onto that, and they're going back to flipping burgers. When they graduated from this prestigious, university in Argentina, those are the things that we struggle with, is the workforce. Students are not going into human services anymore. I mean, you see a lot of that. We've seen a decrease in just the amount of interns that we will see in the social work program and stuff. So yeah, it's a lot of that. I think the need, definitely outweighs what we can do. And I would echo the funding piece of it. Every funder has some different sets of KPIs that we have to follow. And so you're having a whole staff, a whole section of your staff having to make sure that all of that is followed, and not actually doing the actual work itself, but tracking and reporting and applying and showing how good we are compared to everybody else. And it puts us against each other, but that's not the reality. Is that we are doing the work. And so wouldn't it be great if we had this pot of money and we would use already the work that we're already doing and the outcomes we already see to be able to do this, but we don't. And so we're struggling, trying to find those Duke endowment funds, trying to find, these ARPA funds that are one-time thing, trying to find the small little, is it worth a funding request to ask for $30,000 with all the outcome measure they're asking for? Or should I spend that time on that resource with $100,000 with the double of the amount of it? I mean, that's what you're dealing with every day as the leader of these clinics.
Great, thank you. We're kind of drawing to the close here. Let me give a couple of final comments out there about building on Sharisse, what you just said about, there's been a lot of infusion of what I would call one-time money from the federal through the state and local governments. And that's responding to the sort of, spike in need because of the pandemic. But what are the risks and rewards of expanding services with money that you may not be able to replace when it runs out in a year or two?
Well, that's it right there. The risk is making sure that you are financially sustainable after 3 years and all that money goes away and those people still need services, because like we said, we're spending hours and hours on end and it's not going to go away in 3 years. We're hoping that we would see some improvement in their, in their health and their socioeconomic, status, but 3 years is not going to go away. And so making sure that we're sustainable, that we're, have a good strategic plan in place, a board that supports us, and funding that we can have for the long haul, and trying to financially diversify. It's a hard place, which is why I love the MHA capstone students are helping me with that in itself. And, because I don't have enough time. I don't have the bandwidth. My board doesn't have enough bandwidth. Everybody else doesn't have enough bandwidth to figure this stuff out. And going underneath all of the layers of legislation for, even for billing Medicaid for us, we did 7. Is it even worth it to proceed in the long run? Is that even worth it? So we try and trial and error, and you try to figure out, and you hope one day someone sees that you are doing all this work and that, what we're delivering is far outweighs, everything else, and that, we would be able to have sustainable funding in the future.
Yeah, we have to, I totally agree, with everything you just said, Sharisse. The one-time funding, I've shifted to seeing a lot of the government funding as seed money, and sometimes, I opt not to go after it. And when I say government, it could be county money, it could be, federal dollars, state, because it doesn't fit, either timing wise, like Sharisse was saying, and I'm sure Tchernavia, we are stretched. Our team is stretched to the limit. And because of all the background work, the reporting, the tracking, et cetera, that we must do, the meetings in order to make sure that we're all on the same focus, point toward a common mission. That's critically important. So I am so grateful for the funding, but what's quite different versus years past, we're doing more pro formas, to ensure that we know financially, is it sustainable? And if it is, we need to hold ourselves accountable to that pro forma and make adjustments as we go along. But also we have to seek more donor support, and really get the message out to the community. I think all of us, and even those other organizations, nonprofits that are in the same space, we are becoming more and more dependent upon donor support, individual donor support, or support from some of our institutions. And some of that support can come, like Bank of America, from an executive on loan, similar to what you had, Sharisse, your organization, or it can be that type of funding stream. But I have to say, you really have to weigh between the one-time funding versus, is it timely for us, and can we be sustainable once it expires?
I'm going to give each of the panelists now kind of a minute for their closing thoughts and comments, kind of asking you to particularly focus on, what you see as the most critical next steps towards expanding access collectively or with your own organization.
I guess I'll start first. I honestly do need to give a plug to One Charlotte Health Alliance, because that's an opportunity. We really need to support this organization, because it's really representing our major institutions, our healthcare organizations, and the health department. Those are real drivers for making a significant change within the health of this community, and changing the way within the health of this community. Oh, what happened? And changing the way we do business. And so that, along with that, we have to continue to make our voices heard. It's not always a pretty story that we share, but it's an important story, and it's the story of the people that we serve. And I think as long as we focus on the community that we serve, then we'll be able to really glean those answers from them and be held accountable for ensuring that the health of this community improves.
Thank you. Sharisse or Tchernavia?
Ditto. And I would encourage everyone on this call to utilize your own voice and to write your local legislators, your state and national representatives, because it starts at the top. the ARPA funding that many of us are recipients of that are allowing us to expand our services or to strengthen the platforms that we currently have, that's a result of legislation. And that, we want to give another shout out to Congresswoman Alma Adams, who, has our best needs at heart, when it comes to accessible services for healthcare, maternal child health issues, making sure that people in poverty have the things that they need in order to live a semblance of a quality of life. We have such a long way to go, and there's so much more funding and resources that are needed, to many of your points in the chat, in order for us to get to where we need to be. So use your voice. You vote, you pay taxes, right? You're a member of this community, and something like a high ED bill that someone can't pay that goes into charity care, that's then written off, you got to follow the money. We're all paying the price at some point, and no one wants to be sick. No one wants to have a shorter lifetime because of the zip code that they were born in. People don't want to be in poverty, but unless we help individuals who otherwise may not have those resources achieve something like quality of health, then we're going to continue to see those cycles continue. So use your voice, use your time, your talent, your treasure, go volunteer. Reach out to someone that you think may be having a hard time with some of the issues we've discussed today, and connect them to care, and continue to educate yourself on the issues that are prevalent in our community.
Yeah, what she said, and I would urge you to, help us change the narrative of what the people that we're serving are experiencing. They're not victims. They're not, everybody just needs a little bit of help. That's that health equity, I just need a little help so I can get back into the community and serve my family and serve them, change the narrative. If you change the narrative, people will see the people that we serve as people, and that they have a right to these services, quality services, we're not the good charitable clinic doing all of these things because, we feel good about ourselves. No, it's the right thing to do. It is just the right thing to do. So help us change the narrative.
Great, wonderful. Thank you all for those comments. So my wrap up kind of comments as we draw this session to a close really is going back to some things that were said earlier. I think Tchernavia, you started with what I call the preposition problem, about doing with, not necessarily for or to the communities that we're working with. And that really builds on the comment you made, Sharisse, about agency. I've never heard one kind of draw the distinction between determinants and influencers, about these same approaches. We're talking about having culturally appropriate staff, culturally appropriate services, and so forth. Not only having that right preposition, but the cultural values of the agency and our organizations as they do that really empowers and creates agency among the people we're serving. It's not creating or perpetuating a dependency that people often worry about as criticism. You're creating an empowering population that promotes the greater good. And I think that's important as we advance to the comments that were made about the importance of engaging in policy development, about understanding the larger influences, the subtle influences beyond the very specific health policies. And I think that's an important part of civic engagement that you were mentioning that we can all learn those lessons from. So with that, let me thank our panelists and invite you all to put out the applause in the audience that this has been a very engaging and very timely session, a very important session. And as we close, I'm going to just share a couple of slides about the next steps and so forth. Just really to invite you all to join us in the closing session. There'll be a slide on that momentarily, but just close with this thought from Gannon about, in a rapidly changing world, innovation is no longer an option, it's a necessity. And we're here to talk about how to innovate. All the easiest solutions have been found. We now need to find the things where we collaborate together to be innovative and move forward. So with that, again, I thank you all for your participation and look forward to seeing you in the closing session that starts in just a few minutes with Sandra Galea, the Dean of Boston School of Public Health. Have a good day. Thanks.